and goes for testing every 6 months. She tells me about her fear and worry that this time they will find something. I knew that was not for me and decided to have a preventative double mastectomy with immediate deep flap reconstruction. Deep flap is a type of breast reconstruction in which blood vessels, called deep inferior epigastric perforators, as well as the skin and fat connected to them, are removed from the lower abdomen and transferred to the chest to reconstruct the breast after mastectomy without the sacrifice of any abdominal muscles. The benefit of this type of reconstruction is you don't wake up flat and it's not implants. Basically, it's an all-in-one surgery. I found an amazing team at UCLA and was confident that my decision was right for my family and me. My surgery took place on July 19th, 2019. It was a very long surgery, close to 12 hours, and about a 6-week recovery time. I had no fear or doubts going into surgery. I knew that Hashem would be with me and was guiding me the entire way. The night before my surgery, I was able to fall asleep easily and stay asleep until my alarm woke me up at 4 a.m. Thank God, everything went well and I healed amazingly. A few days after my surgery, my breast surgeon called to tell me that pathology found a 2-millimeter DCIS, known also as ductal carcinoma in situ. It is considered the earliest form of breast cancer. 2 millimeters is as small as the tip of a sharp pencil. My breast surgeon was shocked that it was even found. She said it was so small and not detected in any of the screenings I did prior to my surgery. She said there is no telling how long it would have taken to turn into something. I knew I made the right decision at the time, and this reaffirmed it. 3 months after that surgery, I went to have something called a bilateral salpingo-oophorectomy, which is a surgery to remove both of my ovaries and fallopian tubes. I chose to go and have this surgery then, as my BRCA2 status put me at a higher risk for ovarian cancer. My gynecological oncology surgeon suggested taking them out anytime between 40 and 45, as my family was complete with my 3 beautiful children. I didn't see the need to wait to have the surgery. It was a fairly easy procedure, all done laparoscopically. I had 3 small incisions. As my surgeon likes to say, 2 were on my previous incisions, so really she only made 1, and I had minimal downtime. I think it was 2 weeks that I was unable to drive and 4 weeks until I could lift something heavy. I'm very fortunate to have been able to know my BRCA2 status. Both of my parents were subsequently tested, and as it turns out, my dad is the BRCA2 carrier. Many people don't realize that BRCA status can come from either parent, and it's not just from your mom. I can see how Hashem really was with me through this entire process. The timing of me finding out of my BRCA2 status, me not waiting to have surgery, as 8 months later was March 2020, and everything in healthcare for preventative surgery was put on hold. There's no way to know what would have happened had I waited to have my surgery in terms of what was found in pathology. So once again, I saw Yad Hashem and all of this guiding me on my journey. I've chosen to be vocal and an ambassador for this cause because I know how in the Orthodox world that a lot of people are very quiet about this, and I know how it can make a direct impact on people's lives. I've seen people go for testing as a result of our conversations, to be able to take away the fear and face reality versus facing the worst possible outcome. My hope is that by sharing my story, it can take the fear out of the unknown and know you are not alone. I know that my own experience, how important it was to hear from peers who were in my shoes and listened to my concerns and helped guide me through this process. While I was fortunate to receive that help while going through my journey, I am now fortunate to be on the giving side and able to give back to others with the sharsheret Peer Support Network. Thank you for listening to my story.
Thank you, Natalie. We are so appreciative that you did. I think putting a face on this hereditary genetic mutation is really important. And we're so happy that you're thriving and doing well and healthy. Thank God. I'd like to turn now to Sharsheret's genetic counselor, Peggy Cottrell. Peggy is going to give us some more of the background on what it means to have a gene for hereditary breast or ovarian cancer, and fill in some of the gaps in our knowledge. Peggy?
Good evening, everybody. I'm Peggy Cottrell, and I'm going to be first telling you a little bit about Sharsheret. And are my slides there, or should I share them? Looks like I don't.
No, Peggy, I'm going to start to share my screen now, so that we'll have your we will have your slides available in just 1 minute. Here we go.
So Sharsheret is a nationwide organization, is important to mention. Even though we have local offices in about 4 or 5 places around the country, even before the pandemic, our work was really remote. And so we call our patients callers because we talk to them on the phone. We send them packages by postal mail or by email. We have webinars. So everything we do, we can be where you are. So we don't have a Maryland office, but it's not necessary for you to be able to make use of our services. Everything from something like a best face forward kit, a survivorship kit, or a busy box that has parenting resources. We provide personalized support to our callers, and educational outreach. That's what we're doing tonight. And all of Sharsheret's programs are 100% free and open to anyone. So while we like to say we specialize in Jewish in the sense that we have cultural things in our materials, religious things in our materials that appeal to Jewish women, lots of women are able to appreciate and use our resources. So anyone can be in touch with us. And as I said, we support women with breast cancer, women with ovarian cancer, and anyone with an inherited predisposition. Next slide. Is there a way to put this on slideshow so that the slide is bigger, or? Okay. So BRCA 1 and 2 are mutations that, well, the BRCA 1 and 2 themselves are normal genes that we all have. Mutations in those genes occur in all populations around the world. So I think sometimes people think that mutations in BRCA 1 and 2 are just a Jewish thing or just a Caucasian thing, but all the populations around the world have these mutations. And there's also a thought that this is a female thing. And it's important to know that men are just as likely to carry mutations as women are. Now, maybe men are a little bit less likely than women to actually develop cancer, but they're just as likely to carry the mutations. And people with Ashkenazi Jewish ancestry have a significantly higher risk than the general population. And about 1 in 40 people of Ashkenazi Jewish descent will carry a mutation in one of these 2 genes. Sephardim may also have a higher risk. It's not quite as high as among Ashkenazi, but they can also carry these mutations at a slightly higher frequency. Next slide. So I'm just going to start talking about the next slide before we see it. So what do genetic counselors do? What do I do when I meet with people? So one of the first things I want to try to figure out is what's going on in someone's family history. So I'm going to draw a picture of their family tree, and I don't usually draw it as nicely and carefully as this computer-generated version of the family tree. But the circles are women, the squares are men. There are colors to indicate who's been affected with cancer or who carries an inherited mutation. And by visualizing this, genetic counselors are able to do something that's called a risk assessment, and that is to figure out how likely it is that a person carries one of these inherited mutations based on what's seen in the family tree. Next slide. So the importance of having genetic counseling is really to be able to understand the pros and cons of the testing. I think that doctors are more likely to say, you just really need to have this testing done. I'm going to draw your blood and we'll get it taken care of. Genetic counselors are more likely to spend the time to explain how the test is going to help you. Genetic counselors are also good at ordering the correct test for your personal risk and your insurance. Many insurance companies contract with particular labs. So sometimes women think that they don't have coverage for the test, when in fact it may be that it was sent to the wrong lab. And the other thing that's really important, especially once results come in, is that genetic counselors explain the options for carriers. And this is really important as well. Sometimes people will say to me, listen, Peggy, I heard Natalie's story and it's a wonderful story, but I would never want to have that kind of surgery. It's not for me. And it's really important to understand that there are options outside of prophylactic surgery that can be beneficial and can save lives. Next slide. So what if you're looking for a genetic counselor and you want to figure out how to get this testing done? What's the best approach that you can take? So the first thing I recommend is finding a genetic counselor in your area. Now, my role at Sharsheret doesn't really permit me to be able to order a genetic test from my callers. In New Jersey, where I live, a genetic test has to be ordered by a physician. Can we go back one slide? That's really the case in many states. And so you need to be in touch with a genetic counselor in your state. And the way to find someone, first option is to consider something like the National Society of Genetic Counselors. And on their webpage, which you can see the URL there, you can find a Find the Counselor tool. It's on an orange arrow that pops up as you scroll down the webpage, and it's on the right-hand side. And if you click on that, there's a tool to be able to search for genetic counselors in your area. And you could call up at the phone number and find out if they take your insurance and how quickly you can get an appointment, and if it's possible to have a remote appointment. There's nothing about the genetic counseling itself that requires you to be in person, with one exception, and that's collecting a sample. But it turns out we can collect a sample remotely as well. And that's because even though most people think of the best way to provide a sample for genetic testing is a blood sample, it turns out that saliva is also an excellent sample. And so if you have genetic counseling done remotely, the counselor will order a kit to be sent to your home, and you would follow the instructions to spit into the tube and then deliver that to a FedEx drop-off to be shipped to the lab. So it's really become very easy to have genetic counseling done remotely. In fact, there are a lot of providers that are listed on NSGC which only do remote counseling. There are other labs that you can have testing with as well. There's an organization called JScreen, which offers a cancer genetic screening test. Their test is relatively inexpensive. There is a coupon code for some money off. Another lab that's offered testing that you can purchase online is color.com. And so there are options outside of meeting with a genetic counselor in your area. If you're trying to decide which of these makes the most sense to you, you may want to be in touch with me. So if you contact Sharsheret, either from our website or give us a call, you can set up a time to speak with me, and I can answer your questions if you are concerned about whether this is something you need to do or not, and help you find the best way to get a genetic test. Next slide. So some people worry about what testing will do to their insurance. So thankfully, there was a law passed in 2008, was signed by the first President Bush, by the second President Bush in 2008. And this law prevents medical insurance from discriminating against you because of genetic results. So you can't lose your medical insurance because of the genetic test. Unfortunately, it is possible for other types of insurance to discriminate. So life insurance, disability, or long-term care could possibly be affected. It depends on the state. Laws are different from one state to another. There are a couple web links here, which you could use to check out these laws, or a genetic counselor can help you with some guidance as well. Next slide. So we've been talking tonight about BRCA1 and 2, and when we speak with Jewish audiences, those are really the most important because they are significantly more common in our community. However, they are not the only genes out there that predispose to cancer. And so here on this slide, I mentioned a few of the others: ATM, GRIP1, CHEK2, PALB2, PTEN, RAD51C and D, and the genes that predispose to Lynch syndrome. Mutations in these genes cause a different pattern than what we see with BRCA1 and 2. Each one of these genes is unique and causing a combination of the types of cancers you see on this slide: breast, ovarian, prostate, pancreatic, colon, uterine, melanoma, or thyroid cancer. Most of the time nowadays, when testing is done, it's going to be done, genetic testing is done, it's going to be done on a panel that will include most of these genes. Next slide. So just as there are a lot of genes, there are a lot of different kinds of cancer. And so here in this little picture, you see in the first one on the left, this says breast cancer in the middle. And then surrounding it in that circle are written in very tiny letters are a bunch of different genes that could possibly be predisposing to breast cancer. So we have one type of cancer, breast, but multiple types of genes that could be causing an increased risk. Now, on the right-hand one, we see a different mutation. It's not BRCA1 and 2, it's called TP53. And TP53 is a very complex gene that forms a protein that's very important in maintaining our health against cancer. And so mutations in TP53 can cause lots of different kinds of cancer. So you hear multiple cancers can be associated with this single gene. So with BRCA1 and 2, we see risks mainly for breast, female breast, and ovarian cancer. The risk for breast cancer could be as much as 60 to 80%. The risk for ovarian cancer, 15 to maybe 45%. And then risks also for pancreatic cancer, prostate cancer, male breast cancer, and melanoma. So the pattern that we're going to see with each gene is going to be slightly different. And so depending on the results of the genetic testing, you're going to pursue a different pathway for screening or possibly for prophylactic surgery. Next slide. So it turns out that there are other genes that predispose to cancer that we are not really good at looking for yet. And these other genes include something called SNPs. And SNP stands for single nucleotide polymorphism. And since that's a mouthful, SNP is a much better term to use. So if we were to look at a couple different people's DNA, or even a bunch of people's DNA, we might find that there's a certain location where there's a variety of letters that are in the DNA alphabet could be at that location. So maybe 40% of people would have an A at this location, and another 20% would have a G, and maybe 35% would have T. And it turns out that the people maybe who have A have a slightly lower risk for breast cancer, and the people who have T have a slightly higher risk. Now, that risk doesn't make that much of a difference. It's well under a percentage point. But there are dozens and maybe hundreds of these SNPs that could be predisposing to different types of cancer and to other disease as well. And as we learn more and more about these SNPs, doctors will be able to come up with a score that combines all of these SNPs together. And this may be able to explain why we see many families where there's a strong pattern of cancer, but when the genetic testing is done, nothing is identified. So while we're not really perfect yet at doing a SNP test, when someone has a strong family history, then it's important to take that into account, even in the absence of finding on a genetic test. Next slide. So sometimes people have a genetic test, and instead of getting a yes, there's something inherited here, or no, we don't find anything inherited, we sometimes find something which is a maybe, and this is called a variant of uncertain significance. And back when we did only BRCA1 and 2 testing, the chance of finding something uncertain was smaller, and that's because we were only looking at 2 genes. But with today's larger panel tests, even though we are reclassifying hundreds of uncertain variants every month, there are still so many possibilities for uncertain variants. And so again, with the larger test, more of a chance. So if you have an uncertain variant, it means that the lab is not really sure if it's something that's a mutation, or if it's something that's part of normal variation, like something that's just different between one person and another and doesn't change risk, or someplace in between. Now, further studies may clarify a variant of uncertain significance. So if you get this result on a genetic test, it's important for you to stay in touch with your provider in case the lab reclassifies the result. And if we do find something uncertain, we recommend to people that they be cautious about careful screening, but they shouldn't base any prophylactic surgery on an uncertain finding. Next slide. So I mentioned a little bit before that people who do not want to have prophylactic surgery have options as well. So people who have a positive result related to BRCA1 or BRCA2, or in fact, for many of those other genes that predispose to breast cancer, they may qualify to add a screening MRI to their annual screening. And so somebody who normally would have just had a mammogram and maybe a sonogram once a year, if they test positive or have a strong enough family history, they will qualify for this additional screening. Usually the MRI is done at a 6-month interval to the mammogram and leads to the identification at many more cancers at an earlier stage. So this is why it's important to know if you have an inherited mutation, even if you might not be interested in pursuing surgery. Next slide. So what about people who've already had cancer? So sometimes people say to me, listen, Peggy, I know this could help people in my family who haven't had cancer yet, but I already had cancer. There's nothing that can be done about that at this point. Why should I get this genetic testing done? And there are a couple reasons. First, if someone in the family tests positive, it helps us understand what's causing the cancer in the family. And it means that someone else in the family who has a negative result has what we call an informed negative result, which means we know what's causing the cancer in the family and the person didn't inherit it. So a person who has cancer helps their family when they get the testing done. The second reason is the person is going to help themselves. So let's say somebody has already had breast cancer. If it's a mutation in BRCA1 or 2, they might also develop another kind of cancer, like ovarian cancer. And so a person can be helping themselves to find out if they're at risk for additional cancers other than the one they've already been diagnosed with. And finally, there are now targeted medications that can be used to treat people who have an inherited mutation. So again, 3 good reasons to get this test if you've already been diagnosed with cancer. Next slide. So what about men? We said before that men are just as likely as women to carry a mutation. So when you're looking on that family tree, it's important to look at both sides. If we had 100 women who had an inherited mutation, we would expect half of them to have inherited it from their father, just by chance. And unaffected men can pass mutations to their daughters. Next slide. And men can be affected with cancer as well, not as commonly as women, but men with mutations in BRCA1 and 2 are at an increased risk for prostate, pancreatic, melanoma, and male breast cancer. The risk for cancer will vary depending on the particular mutation that's identified. Next slide. So what about updated testing? Let's say someone had testing 20 years ago that was negative. Could something have changed? And so we know that people's DNA really doesn't change that much, but our ability to find things does. So there are something called founder mutations. These are mutations that were founded in the Ashkenazi Jewish population. They actually occurred in the population probably more than 2,000 years ago. Many years ago, it was common to look just for these 3 changes in BRCA1 and 2 and not do a full test. Somebody who had that kind of testing needs an updated test. The original technology that we used to do genetic testing was called PCR. And PCR is a wonderful technology, but it misses certain kinds of mistakes that can be present in the DNA, which include large duplications or deletions. So if a big chunk of the gene is missing instead of a small mistake in a couple of the base pair letters, it's actually harder for PCR to find that mistake. Testing that's done nowadays uses a different technology from PCR. It uses something called next generation sequencing, which allows the labs to test for numerous genes at the same time without generating additional cost. And that's where the popularity of panels has developed in the last, I would say 7 to 9 years. Next slide. So I'm just going to wind up very quickly by mentioning a little bit more about Sharsheret's resources. Some of our programs, for example, Embrace is a program for people who are dealing with advanced or stage 4 metastatic breast cancer. And we have special support for those individuals, including weekly virtual calls with a Sharsheret social worker. Genetics for Life program, that's the program I'm in charge of. And I can speak to people, answer their questions, send out a genetics packet, or allow them to participate in our hereditary cancer Facebook group. That's a private group. We have a Best Face Forward kit with makeup and lotions for people going through cancer, as well as Best Face Forward 2.0, which provides resources for things that may not be covered by insurance, like cold capping, wigs, nipple tattooing, meditation, and yoga. We have regular webinars with experts on a variety of topics, which you can find on our website, and Family Focus Kit, which is for people who are caregivers. So if you have questions about Sharsheret, check out our website, give us a call, and we'll be happy to tell you more about our programs. Thanks very much.
Thank you very much, Peggy. That was an amazing presentation, chock full of information. As Peggy mentioned, the good news is if you missed anything, it was a lot to digest in one sitting, but you can always go to the Sharsheret website and find out how to contact Peggy, as well as see some of their webinars and really learn a lot about the content of Peggy's presentation and also about ways that the organization can assist you. It's a wonderful organization, and I'm really glad that we've had an opportunity to spotlight it here tonight. I did put the organization in the chat, and I will also go ahead and put in the chat another organization called Force that specifically looks at people with genetic mutations. Well, Sharsheret is definitely helps people with that. As you heard, they're also available to speak to people who are experiencing any kind of breast or ovarian cancer, and also their caregivers. And Force is an organization that works specifically, it's not a Jewish organization specifically, but it also works with people who are experiencing hereditary breast and ovarian cancer. All right, now I'd like to turn our attention to Dr. Colette Magnet, who I introduced earlier, who's going to walk us through some of the options for surveillance and treatment. Dr. Magnet, are you ready?
I am, but for some reason I can't share my screen. Oh, did you disable the screen sharing?
Yeah, okay, give
You
me
want
a
me
minute.
to email you my presentation, or?
Are you able to turn on your video?
You know, I can't, my video will not turn on.
Okay, well, I think you should be able to share your screen now. Give it a try.
Let me try. Okay, thanks.
It looks like you might have your camera covered. You should look at your camera and see if there's something to open.
Oh,
Your camera may be on, but covered.
so let me see. I wonder how you would uncover it.
Well, that's okay. We're looking at your
See my-
screen now, but you
yeah.
just have to go to the tab that says the genetic PowerPoint.
Oh, yeah.
Or on the meeting registration.
Don't let this worry you all. I have everything under control. First, I would like to thank Peggy for a great presentation. The role of a genetic counselor cannot be underestimated at all. I've been lucky enough to work with genetic counselors my whole career, and I think that, you know, I never send genetics myself because I think that I'm really not the best person to decide what genetic mutations a person should be tested for. So I agree with everything Peggy said, and I think that it's an incredibly important role. One of the things that she touched on was that we have certain medications that we use for patients with genetic mutations. And so there's something that you all may have heard of called PARP inhibitors, and PARP inhibitors are drugs that can really lower the chance or decrease the risk of either a breast, ovarian. We use it in pancreatic cancer now with patients with BRCA1 and 2 mutations. Really lowers the risk of those cancers coming back. So I have patients who have been on PARP inhibitors for, 3 years, who have had pancreatic cancer, breast cancer. So those are incredibly important, and that's why we want to get all the genetics done. The other thing is that certainly with the BRCA1 patients, we worry about triple negative breast cancers, and that's why it's so important to have the genetic testing done so that we can try to prevent triple negative breast cancers, because 80% of the cancers that BRCA1 patients develop are triple negative breast cancers, which, as you all know, are very recalcitrant to treatment, very hard to treat, and tend to be very aggressive. So my approach when I see a patient who has a genetic predisposition to breast cancer is I try to kind of tiptoe in there initially, because a lot of the patients have just found out they have a BRCA mutation, and it's not a fire drill. There's no rush to make decisions. There's no reason to really alarm the person. I find that it's best to just approach it calmly, gently, and give them time to make their decisions long term. Certainly the option of surveillance is very, very good. I've had patients that have gone, who have BRCA mutations, who have gone 20, 25 years without breast cancers. So you certainly see patients that don't develop breast cancers, as you know. So in terms of surveillance, Peggy kind of stole my thunder on this, but I just wanted to go over surveillance because, as we know, all surgeons like to operate, but I don't want you to think that we do this without really thinking about it. So surveillance, we usually try to see the person every 6 months. That way we can keep track of them, do their examination, look for things that we may want to get some imaging on. We alternate bilateral diagnostic mammograms with ultrasounds and bilateral breast MRIs every 6 months, as Peggy said. The other thing that's important, really, I think, is to teach the patient breast self-examination, because I think that especially young women will find their own cancers. That's not uncommon, and because they're not getting mammograms. So, although these genetic patients with genetic mutations do get mammograms and MRIs, it's good because you may feel a lump yourself. And I just tell people, I think the best way to do that is to soak up your breasts in the shower and see and just run your hands over them, and usually do it at the end of your period. You can, women find their own breast cancers, even though they say, I have no idea what I'm feeling. They do find their own breast cancers. And the bottom line is it usually feels like a hard rock. Breast cancers, when you cut them and you look at them, they look like quartz. So they really are very, very hard. The other thing is there are patients looking for any skin dimpling, creasing, or nipple discharge or inversion. We usually like to start screening about 10 years before the youngest family member's onset of breast cancer. So that's when we kind of get things rolling. So for example, I have a patient who developed breast cancer at 35. So we started her daughter around 23, 24. And then in terms of preventive surgery, the standard of care now is nipple sparing mastectomy and some sort of a reconstruction. So it depends on the patient's, the type of breast the patient has. If patients have breasts that are very pert and easy, I'm pointing to my breasts, of course, you can't see me luckily, because mine aren't pert, but if patients have very pert breasts, then, and they haven't breastfed a lot of kids, then we can just make what we call an inframammary incision, an incision underneath their breast, and then scoop everything out, preserving the nipple areolar complex and all the skin of the breast, and then put something like an implant in. But patients that have what plastic surgeons euphemistically call ptosis, P-T-O-S-I-S, which just means gravity. It means, things are going south because the person has breastfed kids, or a variety of reasons. It's just genetics too. Genetics about what your breasts do with how they look. So anyway, so what we do in that situation, if a patient has ptosis, we worry that the nipple areolar complex is going to end up not looking good. It's going to be in a funny spot if we make these inframammary incisions. So what we often do is do a breast reduction or a lift about 3 months prior to the mastectomies and reconstruction. So we lift everything up, and then about 3 months later, once it's healed, then we do the nipple sparing mastectomy and reconstruction. So in terms of breast reconstruction, Natalie was kind of going over some of this with her deep flap. The two main types of breast reconstruction are tissue expanders or implants, and then the other one is autologous tissue, which is the patient's own tissue. So in terms of the implant reconstruction, what we started doing in the past several years is we've always put the implant underneath the muscle, so that when the implant's underneath the muscle, if a person flexes their pec muscle, their implants move up and down, just like that Terry Crews ad, that basically the implants will move up and down. So we call that animation deformity. And so what we try to do now is, if the person has enough fat and so we have skin and fat over the implant, we don't put it under the muscle, we put it above the muscle. And so that's used very frequently now. And the good news about it is it causes less pain, because you don't have to pull up the muscle and put the implant underneath it. And there's less movement of the implant with exercise. So those are the two basic places that we put implants, but really going towards this pre-pec or on top of the pectoralis major muscle. The pros and cons of implant reconstruction: the pros are it's shorter surgery, faster recovery, no other body part is changed. The cons is that implants can only be so large. So 800 cc's is the biggest implant you can have. So if you have a patient that has really large breasts and is kind of a big person, the implant may just be too small for them. The other thing is that implants are more likely to get infected than autologous tissue, because it's a foreign body. But the implant reconstruction is ideal for thin, but as plastic surgeons say, but not too thin women without ptosis. So if a woman is extremely thin, then we don't have enough covering over the implant. And in that case, we tend to put tissue expanders in, and pump them up and then put the permanent implant in later. And so when do we decide whether we're going to put in tissue expanders or if we're going to put in a permanent implant right away at the time of surgery? It partly depends on what the blood supply to the skin is at the surgery. So autologous tissue reconstruction, the first is the deep flap, as Natalie spoke about, and that's taking the abdominal tissue, and basically it's the skin with the underlying fat and the blood supply. And that is, and so that it would be divided in half if you're doing both sides. And then it's the blood supply is hooked up to some vessels that are under the rib. So a little piece of rib has to be removed on each side to do that. So deep flap, it's a great way to have a reconstruction. It does involve a lot of surgery. So like Natalie said, 12 hours. It can, you can get that down to about 6 hours if you have two surgeons working at the same time. So a lot of times two plastic surgery partners will do the deep flaps together. There's something called the S-gap flap. And so the S-gap is a superior gluteal artery flap. And this is, so in the deep flap, muscle isn't taken, and the S-gap muscle isn't taken. So basically the scars on the top of the buttock, just right around the top, and then an oval of skin, fatty tissue, and the blood supply is taken and then hooked up to these vessels as well. So it involves microvascular surgery. So only certain plastic surgeons or reconstructive surgeons really should do this. And these are people that do the deep flap and S-gap that have trained in microvascular surgery. There's a flap from the back that's very good, latissimus dorsi flap. And so that's back tissue. And that's, if a person has small breasts, you can use that to reconstruct. You keep it hooked up to the blood supply and swing it around. But it's also used with an implant. So that's the sort of the worst of both worlds, that you're doing both a flap and an implant. But it works really nicely for some people. So those are all the kind of things we have in our armamentarium. Deep flap, which we were talking about, no muscle is taken, can take several hours. The advantage is that the patient's tissue is used, so the patients really like this, and more patients are moving towards deep flaps. The thing is, it's less likely to become infected or form scar tissue. There's no implant, and so patients are much happier about that, but it is a huge operation. The S-gap, a lot of people, so the incisions made along the top of the butt, along the top of the buttock, and then these are generally performed in patients with not enough abdominal fat. So if, when patients come in, I say, okay, let me see your belly, and then they show me their belly. Oh yeah, I have plenty, but it's often not enough to reconstruct two breasts. Some patients are moving towards no reconstruction. It always shocks me that patients do this, and then they put a prostheses in their bras. But we do have even young patients that decide not to do this. I try to talk people into reconstruction. I just think it's a better way to go. Just easier on the person, easier psychologically, but some people just don't want it. So I know this is kind of this was kind of superficial. I try to do surveillance on patients until they're ready to think about doing surgery. It's a reasonable way to proceed in patients with a genetic predisposition to breast cancer. But at some point, often after the childbearing, most of these women decide to undergo preventative bilateral mastectomies, most likely with reconstruction. They say that the bilateral mastectomy will decrease the risk of cancer to somewhere between 5 and 10%. And nipple-sparing mastectomy has been shown to be safe in these patients and greatly improves the cosmetic result. So I thought I would just leave time for questions. And I know I was asked, we talked about whether I should show pictures. If you would like to see pictures, I would be happy to email them to you. Thank you.
Okay, thank you so much, Dr. Magnet.
my
That was
screen.
amazing. If now yes, you can stop. Sharing screen. That's perfect. Thank you. So we're going to take questions in a couple of minutes. I'm going to look through the chat and also see if people who wanted to ask any questions anonymously, I can go ahead and ask that on their behalf in just a second. Just as a wrap up, again, I know there was a lot of information tonight. We had the great fortune to have two real specialists in their fields present to us, and it was really invaluable. It's not an opportunity that you often get outside of a genetic counselor or a doctor's office. And I think some of the takeaways would be that if you came to the presentation tonight because you had any concerns about your own genetic history or family members, great place to start finding out more information is certainly sharsheret. Wonderful resources that you can find there. You can also locate, and we can help you with that. At the end, I'll mention you can also, if you need to get some of the information that Peggy offered earlier, she put her direct email address in the chat. If you miss any of that, if anybody emails me, if they want to get in touch with Peggy and they can't, or with Dr. Magnet, or to find out about genetic counselors in our area, please do. I'll put my email in the chat as well shortly. So the best place to start really is with a genetic counselor. If you have not yet tested and you have an interest in possibly doing so or learning more about the benefits, and genetic counselors, I think, can go through a lot of the options with you about what's available after you test, and should you find out that you do have a genetic mutation. I think that Natalie is a great example for us, that the surveillance options and the prophylactic surgeries are things that people can live with, and that finding out that you have a genetic mutation is not a cause for alarm. It is, as I said earlier in the program, at the beginning in the introduction, it's actually a wonderful tool. Knowledge is power. When you have this knowledge, thank God today, so much research has been done. There are many, many years now of evidence that has been gathered on the surveillance and on the surgery options that really show how they can be beneficial and contribute to people's overall health and longevity. So we're living in a very fortunate time period for this. And the more you can find out, if you have concerns, the more likely you'll be on the road to actually being able to manage your concerns and your fear and contributing to getting on the road to good health. So that it's very, very exciting time. Thank you to all the speakers. I'm going to quickly look in the chat here. It looks like we have one note that Medicare pays for only one genetic test in a person's lifetime. That's an interesting note. So seniors should be aware of any scams about genetic testing and telemarketers. And I think that's a great point. You don't want to just randomly go find a genetic test. There are a lot of good options. And again, I'm going to point you back to anybody who's interested in this should probably get in touch with sharsheret and speak to Peggy, who will make sure that they get the good test and are not in any way put in touch with a scam. Here's a question. Is there an age after which it isn't worth getting this genetic testing? I'm going to pose this first to Peggy. Peggy, is there an age at which you really shouldn't bother anymore? After an age that perhaps you're no longer likely to get breast cancer due to genetic reasons? Is there a cutoff for the test?
There really isn't a cutoff for the test. And that's because, especially if someone's been diagnosed with cancer, it would be a good idea to know if it was a result of something inherited or if it was something that happened by chance. I would think that someone who is much older and doesn't have any family history of cancer probably doesn't necessarily need to be concerned about this. But certainly someone who's been diagnosed with cancer could consider this testing.
Okay, thank you. Another question, what if somebody was tested way back when, you mentioned the early days, when there's only the test for BRCA 1 and 2 and not the full panel? Should they get tested again?
So it really depends on exactly what the test was and what the result was. So if someone had testing, I would say more than 10 years ago and had a negative result, then it's going to be a good idea to think about pursuing another test. And that's because before 10 years ago, a panel test wasn't offered. And the technology that was used may not have found all the mutations in BRCA1 and 2 that might actually be identified with today's technology. So if you're concerned about whether you should have another test, then bring your test to a genetics expert and have them take a look and see if they think you need to be retested. Now, if your result was positive, then it may not be as necessary to get retested, because the other genes that we look at don't increase the risk of breast cancer as much as BRCA1 and 2. So it's people whose results were negative who really have to
Okay.
think.
So if somebody already had, and follow-up question to that, if it was somebody that tested positive in the old days, before the full panel was available to either one of BRCA1 or 2, should, and their children, their other aunts, their family members went ahead and got tested based on that result and tested negative, should they test again? And because in the event that there was some other mutation, in other words, they didn't have the prophylactic surgery, they didn't have the screening. So should they go ahead and test a second time for the full panel?
So if there's been a mutation identified in the family and a person's negative result means they didn't inherit that one, then the main time that I would recommend additional genetic testing would be if there are cancers in the family that aren't explained by the mutation that was identified. So let's say there's a family with a BRCA mutation and a couple cases of breast and ovarian cancer, but there's also a lot of colon cancer. So colon cancer is not really part of BRCA1 and 2. And so then that might be a situation where it'd be a good idea to see, is there something else in addition to the BRCA1 and 2 that could be causing the additional cancer? But these are all, this whole line of thinking are complex questions that generally make sense to bring that to the attention of a genetics expert and say, did I have enough tests? Is this something that needs to be redone? And then you can be reassured.
Thank you. Thank you very much. There's a question that's a little bit similar, but a little bit more nuanced to the earlier one about, is there an expiration date for getting this? Somebody said that they know that their mother was BRCA1 positive, but she's already hit 70. She never got breast cancer. So, and she also has aunts and cousins that are positive for the same mutation. Some of them have gotten sick, but her mother has not. Is she at any less risk because her own mother is 70 and has not had cancer?
So it's a complicated question. We know that there are other factors outside of the mutation itself. So other genetic factors, other lifestyle factors, and chance come into play in terms of whether or not someone develops cancer. And so we know there are things that people could be carrying that are somewhat protective and make them less likely to get cancer, or they could be carrying things that make them more likely to get cancer. We don't know what a lot of these other factors are. And somebody, let's say you're the child of someone who seems to have been protected and you did get half of your DNA from that parent, but you also got half of your DNA from the other parent. And so we don't know, could there be something you inherited from the other parent that could make something come out worse? In other words, there really are a lot of unknowns here. And so we want anybody who's tested positive to continue to have the careful screening, I think probably past age 70. Now, once someone gets to age 70 and hasn't gotten cancer, I think to then decide to have prophylactic surgery may be unnecessary. Clearly, the chance to get cancer once you get past 70 is a little bit less. And that's because you've used up some of your risk by actually making it to 70 without getting cancer. So again, all questions that it's really important to bring these issues to your own healthcare provider and get those good questions. But those are general guidelines that can apply.
Thank you. I have two more questions from the chat that I think are are good to bring up. One, again, for you, Peggy, and one perhaps for you. And I think if Natalie is still on, it might be interesting to hear her thoughts on this as well. So one of the questions, Peggy, is what about 23andMe? Any opinions on that? Is that something people should be using for this?
So interestingly, 23andMe uses a very different kind of technology than next generation sequencing. And so when they do their test, they're only looking at the founder mutations. And so the overwhelming majority of BRCA mutations that are out there in the world will not be detected by their test. And they know this. I'm not saying something that they wouldn't say. They will tell you on their site that if you have a medical finding of some sort, that you should really confirm it with a medical grade test. So what we just like to remind people is that 23andMe or other direct-to-consumer testing like Ancestry can be entertaining to try to find out about your ethnic background or to look for long-lost relatives and the like. But if you have a medical concern, that's not the test you should go to first. If you have a medical issue, you should have a medical grade test.
Okay, great, thank you. All right, and last, I'm going to combine a couple of questions here. I think the last question in the chat is, if somebody is positive for one of these genetic mutations, number one, when do we recommend talking about it with children? At what age? And number two, at what age should they be tested?
So the age at which parents talk about these issues with their children is very variable. And I will tell you, I know of people who wait until their children are adults to tell them. And I think that that's absolutely fine, because sometimes talking about this with young children causes them a lot of anxiety. But on the other hand, I know people who've told their children when they are younger, and it has worked out fine for them. And it really has to depend on some level of the style of the family. But an individual is not old enough to have the test done until they're at least 18. And we think that it may be even better to wait to have the test until you're closer to the age where you might do something differently, which is 25. That's the age at which you might consider starting to have a breast MRI. And so that's really what's at play. So if you tell your child about this when they're 15, then they're not going to be able to have a test for a couple of years. And maybe that causes anxiety, and maybe it doesn't. What I generally recommend to people is to tell their children about this in a stepwise fashion. So just the same way when you teach your children the facts of life, sex education, you don't tell them everything in one sitting. You tell them a little bit at a time at an age appropriate and developmentally appropriate stage. And so you might tell your children, you know, I go to the doctor and you go to the doctor every year because we're trying to keep ourselves healthy. And that's a really important lesson. And look around our family. There've been a lot of people who've had cancer. And so mommy has to make sure she goes every year and get her checkups just to make sure that I'm taking good care of myself. And then eventually that knowledge can turn into, there is something that's been identified and you could be tested for it. But that may not be the place to start. It may be better to start with something a little bit easier for a child to take in.
Okay, thank you. I appreciate that. That's great advice. I don't know, Natalie, did you want to, if you're on still, is there anything you wanted to say in your own personal experience about talking with children?
So I told my children only right before I was having surgery. I think it was like the night before or 2 nights before. I didn't see the need for them to know when I was going to all my appointments and meeting with all the doctors and, you know, making a plan. I didn't want to burden them with having to be worried about what does the surgery mean. There's actually a really good book. I'll send you the name after. It's about it's written by some nurses from one of the breast centers in Houston. I think it's PRMA, and it talks about having the genetic mutation, a BRCA mutation, and how you're going to have surgery. That one only talks about implants, but it really broke it down very nicely for my kids to understand, because it's like a cartoon kind of book, and it really helped them know what I'm doing. So instead of saying, you know, I just I didn't talk about like implants or whatever, because they said, oh, the implants are like gummy bears. And my daughter, who at the time was 6, she thought it was hilarious. So when I was in the hospital, she told one of my best friends, Mommy got gummy bears in her body. And she's like, what are you talking about? But so she understood enough of the book to like know what was going on. And, you know, I don't think they were a little inquisitive, and they want to know, like my son was a little bit emotional, like he was crying because he didn't want me to go for surgery. But they didn't ask so much detail. I mean, at the time my son was 10, my one daughter was 8, and the other one was 6. So they, you know, there wasn't the capacity to ask so much wasn't there. But the book really did help. And then I know after the surgery, they did look through the pictures and like try to read the book and know kind of what I went through. And I'm not planning on having them do any form of testing or anything until they're 25 or older, because there's no need to burden them with that information. I didn't find out till I was 40. So I think it's fine to wait. Their doctors know. So, you know, when they're going to have their yearly exams, they know to be on the lookout if they feel anything, see anything, notice anything. But that's really as far as it, their doctors want to go with it for my kids.
Thank you. Thanks, Natalie. That's great. And I love the gummy bear story. That's going to stick with me. And I think it also points to the fact that, like everything else, there's no reason not to have humor when discussing these things, and every conversation can have positivity. I know lots of people are also concerned for some other aspects that we didn't touch on tonight. Some people want to talk about the halachic pieces of this, about what you can do and not do for surgery, and are there any concerns? And that has been discussed at great length by rabbis, and we can certainly have another program where people can have that concern, and also some of the concerns that people still have, although I think it's diminished greatly. There are still some concerns about stigma and people worrying that other people will know that if they have this genetic mutation, they may not want to marry to their family. And I think that's really decreased a lot. But it still exists, and that is part of the reason that Bikur Cholam of Greater Washington really wanted to have this program, to just take some of that concern out of the picture. And I think Natalie really has been a wonderful person to show that and lead the way on that, and to remember that really all of us have, our DNA is complicated. We all have predispositions to various things. One of the great things about some of these mutations is that you can actually know that you have it, and you can actually do something about it. So I would say that maybe people should want to marry into families that have this gene, because it's one of the more controllable things. And of course, it also has a very high prevalence in the Jewish community and the Ashkenazi Jewish community in general, whether people know about it or don't. I'd like to just ask if anybody would like to unmute and ask a question of any of our panelists. This would be the time to do that. Do you have anybody who's interested? Okay.
I just want to say my daughter found it. She heard me talking, so this is it.
Oh, okay.
So I'll post the title for you so you can see it.
Okay, that's great. Thank you. Thank you very much. Well, all right then. I want to thank Dr. Magnan, who was very generous and said she would be willing to email pictures if anybody would like to see what some of the surgical look like afterwards, and privately. And Peggy from Sharsheret, so generous with your time and information, and can be contacted at Sharsheret. Natalie, can't thank you enough for coming out and speaking on such an important topic tonight, that it has affected you and your family on such a personal level. And I hope that you will go to our website, Bikur Cholam of Greater Washington, and sign up for a newsletter, which is essentially getting on our mailing list so that you can be alerted to future programs. You can also email me, and I'll put that in the chat in just one second, to if you have any questions about this program that weren't answered, anybody that you'd like me to get in touch with on your behalf, or to get you any more information. There's my email address. Please feel free. And thank you. Thank you, everybody. Thank you again to Serena Singer and Amhat Torah congregation for helping bring this program to fruition. We deeply appreciate it. Have a good night, everybody.
Good night.
Good night. Good night.
Good night.